L4, L5 disc prolapse. This one favorite question of the examiner, doctor. L5, S1, L4, L5, L3, L4, you must know everything. Okay. 3 levels. What are they? Motor, sensory, reflex. ये तीनों के बारे में you need to have a complete perfect answer. L3, L4 disc herniation में क्या होता है? L4 root get compressed. L4 root will be supplying what? Sensory loss on the great toe and the medial side of the leg. Motor loss of weakness of the extensors of the knee, and the knee jerk is the one which become absent. That is the story of L3, L4 disc prolapse and the L4 root compression is what you need to remember. Then L4, L5 herniation, what will it do? Yeah, I think now the video broadcast is little better. Hopefully, yeah. L4, L5 disc herniation will lead to the L5 root compression, and there is a sensory loss on the lateral side of the leg and the dorsum of the foot, and the motor loss may what will be there? Weakness of extensor hallucis longus, foot dorsiflexus, ankle jerk is normal, not affected. Ankle jerk is S1, that's the reason. Okay. So, but where is the sensory loss? Lateral side of the leg and dorsum of the foot, not the plantar aspect. Whereas L5 S1 herniation will lead to S1 root compression, and the sensory loss is along where? Lateral side of the foot, and motor loss has got a weakness of the plantar plexus and the ankle jerk become absent. So these 3, doctor, one of them is going to one of these 3 is going to be the very high yield area for the examiner, which you have to be 100% sure. Now there is a radiograph. What is wrong about it? First of all, what is the type of fracture? Galeazzi is what you need to basically remember. So first, if you understand that is Galeazzi, you must know few facts about Galeazzi. What are they? Yeah, they are the most likely fractures which undergo malunion, not non-union. All the remaining are true. It's called fracture of necessity. That is, you have to do the surgery. Recent TNPG, we had the same question. Then it can predispose to compartment syndrome, anteriointerosseous nerve palsy can be there. Any of them can be the true statements is what you have to basically remember. Now doctor, what is this fracture according to Salter-Harris classification? So you must see whether epiphysis, metaphysis, diaphysis, how is the fracture line basically is extending is what you have to look for. So basically, if you look at it, it is a class 3. Type 1, type 2, type 3. Type 3 may, it is basically extending from growth plate involving the metaphyseal area. So one of the type of whether epiphysis, metaphysis, diaphysis, all the 3 involved or what is involved you have to look for. Vitreous ka structural component typically is composed of what? Basically it is type 2 collagen. It is made up of is what you need to remember. Then most important glial cell in retina hota hai Muller cell. Muller acts like a supporting cell in the retina and act like a glial tissue. Lattice degeneration में what percentage of retinal detachment होता है? ऐसे questions को छोड़ना. For that reason we have given it. So in about 30% of patients, it's not in your hands. Then yeah, this is how basically the lattice degeneration looks like. Looks like, doctor. Pseudoretinitis pigmentosa. What is the importance of retinitis pigmentosa? My retina ki picture. You have got bony spicule appearance, hyperpigmentation, etc., etc. Is it not, doctor? So, what other conditions can lead to a similar kind of a hyperpigmentation of the retina? Basically, you have got the syphilis, toxoplasma. All of them are known to lead to development of similar pseudoretinitis pigmentosa like picture. Retinitis pigmentosa, once more, another high yielding question. Most frequent type of the cataract which you basically come across, kya hota hai? Basically, it is a posterior subcapsular cataract is the one which you will come across. Largest size of the intravitreal C3F8 in 0.3 ml is reached by how many hours? ये छोड़ने वाला question है. Now you know the practice. But it is actually asked in JKMD. Okay, doctor. So it is about 72 hours is what you need to remember. ये भी छोड़ने वाला question है. PFCl which has highest molecular weight. To know IOL's composition and their molecular weights is too much. You are not post MS after fellowship candidates for vitreoretinal surgery exam. But still, examiner will ask such questions. Huh? So, ये भी छोड़ने का है. I leave the molecular weights for you. Sometimes क्या होता है कि like this epidemic of tough questions of a particular subject will come. Don't think all question paper will be like that. Like Sapta Maharshis, you have 19 Maharshis setting up the paper. Only mark test is composed by one Maharshi, Bharadvaja. But actual exam when you go, no, you have Pura Sapta Maharshis, 19 Maharshis sitting there. One Maharshi will be Moody Maharshi. Oh, I want to know how much is the silicon content in Antarctica ocean. He'll have his own fantasy questions. Kya karenge aap? So, don't be disheartened. Sthitadi munivruhyati. The one who is having stability, ability, agility of the mind, not tampered by either success nor failure, nor bothered about defeat, not elated by the success, with defiance in defeat and magnanimous to victory. That should be your composition of the mind to face the exam, doctor. Let me tell you. So if one very tough question comes, you never read kind of a feeling, don't worry. You have got another 160 you have to swim through. The least addition of silicon oil is observed in which situation? What type of IOL? Once more, IOL's composition, best question, heparin coated, etc. Silicon IOLs. Regular PMMA. If you take regular PMMA has got the least addition of the silicon oil is the point to be understood. Yeah. Then doctor, on an average, I never know these questions except for preparing for mock test discussion. Silicon filled phakic eye will produce how much of hyperopic shift? What's the question? इसलिए मैं बोल रहा हूं एम्स का खाली करना, एपीजी क्वेश्चंस खाली करना या जिपमर क्वेश्चंस करना. All questions asked in the previous paper में, every question paper में 20% useless questions never will they will be repeated, will be there. अगर आप क्वेश्चन पेपर को ज्यादा इंपॉर्टेंस दिए तो क्या हो जाता प्रीवियस पेपर्स को? You will try to grab all those 20% never repeated useless sporadic stuff which come like meteors and asteroids. You have to look for stars and prepare for exam. Not be guided by meteors and asteroids which come rarely. Okay, doctor? So that's the reason. Be sure, be specific. Yeah, the answer will be 6 diopters. Then, if there is a non-traumatic giant retinal tear, doctor, I did not compose these questions just to make you unhappy. JKMD ka original questions, same things I am representing back for you. Huh? So, 30%. I can say 200 marks में 10 marks तो definitely will not come for students. I mean 10 wrongs तो जरूर जाएगा. अगर वो guess मार के कोशिश कर रहे तो another 5 marks भी निकाल दो. 185 it won't cross. Huh? तो non-traumatic giant cell tumor, giant cell tear, right? हाँ. Now doctor. Yeah. Then comes doctor. Epstein, now see, suddenly after starvation you get rainfall. But if you lost your tempo in octal questions, isko bhi kharab kar diye to your fiancé cannot anymore wait. Already बहुत waiting करके बैठ गया, कब आप exam खत्म करके आओगे, right? So it is Burkitt's lymphoma, nasopharyngeal carcinoma, infectious mononucleosis. They are all caused, not laryngeal papillomatosis, which is basically HPV, as all of you know. Transconsioscopy. ये भी थोड़ा outlier. So, is a surgical procedure for what? To basically look at the subglottic space and parapharyngeal space. The transconsioscopy is a technique which is being used. Don't worry if you answered this wrong. What is the early sign of tubercular nodes at the bifurcation of trachea? JKMD 2005. Another difficult question. Non-blunting of keel. Keel kya hota hai? Tracheal bifurcation hota na? Carina will be there, no? Whenever you are looking through the laryngoscopy, the carina will produce a prominence in that laryngeal interior. अगर वो नहीं दिखा के blunt हो गया तो that is indication of tubercular node. So very difficult. These two questions out of the game. Then, this is easy question. Nasopharyngeal angiofibroma, purely prepubescent males. Pubertal boys, never for girls. That's a very routine question. So this is how nasopharyngeal angiofibroma, and is he boy or girl? We don't know, but he's a boy actually. Then in middle meatus, nasolacrimal duct doesn't open. This is the most routine traditional question which you can assume. Nasolacrimal duct opens into inferior meatus. About the fungal infections, rhinoscleroma is not Klebsiella, rhinoscleromatis is the one which is responsible, which is not fungus.